So doctors, I would like to show you today's topic, orofacial clefts. Learning objectives of this presentation. By the end of this presentation, participants will be able to recognize the different types of orofacial clefts, describe clinical features of orofacial clefts, understand some epidemiological features of orofacial clefts, apply tips for coding and reporting different situations. At first, cleft lip and palate are the most common congenital craniofacial anomalies treated by plastic surgeons. Between the 6th and 12th weeks of fetal gestation, the left and right sides of the face and facial skeleton fuse in the middle. When they do fail to do so, the result is a craniofacial cleft. It is possible that facial clefts are caused by a disorder in the migration of neural crest cells. Another theory is that facial clefts are caused by failure of the fusion process and failure of inward growth of the mesoderm. Incidence of orofacial clefts. More common this pathology in South Asians, 1 per 500. Less frequent in Africans, 1 in 2000. Prevalence in Europeans and Americans, 1 in 750. According to data of these authors, prevalences in Pakistan, 1 in 523. In India, they register 27,000 to 33,000 per year. Moreover, boys are more affected than girls by 3 to 2. Cleft lip and palate occur twice as often in boys as in girls. Isolated clefts of palate are more often in girls. 75% of clefts are unilateral. Rest of them are bilateral. And left side is more involved than right side. And now let's find definition. What does it mean, cleft palate? Let's look at a famous source called Britannica. And according to this source, cleft palate, it is congenital deformity in which the palatal shelves in the roof of the mouth fail to close during the second months of prenatal life. Background of this topic. The cleft palate was not recognized as a congenital disorder until middle of 16th century. For centuries, perforation of the palate were considered to be secondary to syphilis. The first successful closure of a soft palate defect was reported in 1764 by Lemonnier, a French dentist. The first closure of the hard palate was performed in 1834. Clefts occur more often in kids of Asian, Latino, or Native American descent. And now let's mention about anatomy of the lip. This picture depicts anatomical features of the orofacial area that are usually mentioned when discussing the anatomy of orofacial clefts. These include the philtrum, two philtrum columns, nasal cells, cuspid bow, vermilion border, and oral commissures. And now let's talk about anatomy of the palate. This sketch shows the anatomy of the palate. You can see the primary palate, which is the triangular area in front of the incisor foramen, including part of the lip and alveolar ridge, and the secondary palate, which extends from the incisor foramen to the uvula. The secondary palate is divided into the hard and soft palate. Here you can see the schematic diagrams of the development of the lip and palate in humans. The first, sketch A, shows the developing frontonasal prominence, paired maxillary processes, and paired mandibular processes that surround the primitive oral cavity by the fourth week of embryonic development. Sketch B shows the formation of the nasal pits which occur by the fifth week and lead to formation of the paired medial and lateral nasal processes. Medial nasal processes and lateral nasal processes. In sketch C, the medial nasal processes have merged with the maxillary processes, green color, to form the upper lip and primary palate by the end of the sixth week. The lateral nasal processes from the nasal ale form the nasal ale, right and left. Similarly, the mandibular processes fuse to form the lower jaw. Sketch D is during the sixth week of embryogenesis. The secondary palate develops as bilateral outgrowth from the maxillary processes. Which grow vertically down the side of the tongue. Subsequently, shown on sketch E, the nasal palate shelves elevate to a horizontal position above the tongue. Contact one another and commence fusion. The final sketch, F, is where the fusion of the palatal shelves ultimately divides the oronasal space into separate oral and separate nasal cavities. And now let's remember about well-known your information about dentofacial area formation in utero.
The facial features of the human embryo develop rapidly very early on in pregnancy, beginning around the 4th week after conception. Many of the structures of the face originate from a group of cells called cranial neural crest cells. These cells move in a distinct pattern from the neural tube located in the back of the embryo to create the various structures of the face. Aberrations in the formation or behavior of these cells are the main causes of abnormalities in the head and face. During the first 3 days of development, the fertilized ovum, or egg, is located in the fallopian tube. As it travels down the tube, it undergoes rapid divisions to form a cluster of cells called the morula. These cells then organize themselves to form the blastocyst, and by the end of week 5, the fully formed blastocyst comes into contact with the uterine wall for implantation. During the 2nd week of development, the inside of the blastocyst, known as the embryoblast, becomes 2 layers, the hypoblast and the epiblast layers. Together, these layers form an oval-shaped disc-like structure. In the 3rd week of development, a streak is created on the surface of the epiblast, during which time the cells of the epiblast detach and migrate. These migrating cells create 3 layers, the ectoderm, mesoderm, and endoderm layers, which go on to contribute cells to form all the tissues and organs in the human body. In the 3rd to 4th weeks of development, a cord called the notochord is formed. This induces the cells in the overlying ectoderm to thicken, forming a region called the neural plate along the back of the embryo. The edges of the neural plate elevate to form the neural folds that eventually fuse to form the neural tube. During this process, neural crest cells are formed along the entire length of the tube at the tip of the folding neural folds. Neural crest cells formed from the head or cranial region are called cranial neural crest cells, or CNCCs. These cells multiply and soon start migrating over long distances in distinct paths from the back of the embryo towards the front of the embryo. Once they arrive at their target destinations in the facial regions, CNCCs further develop and mature and ultimately contribute to a substantial amount of the structures in the head and neck region, such as bones, cartilage, and nerves. Growth, migration, and subsequent differentiation of CNCCs are critically important for proper development of the normal structures of the facial region. Soon after the CNCCs reach their final destination, the facial structures begin to take shape externally. By the 4th week of development, the embryo is characterized by 5 facial swellings, the frontonasal prominence, and the paired maxillary and mandibular prominences. These structures are formed in part from the migration and proliferation of the CNCCs from different regions of the neural tube. In a 5-week-old embryo, the nasal placodes, which will go on to become the olfactory system, and the optic placodes, which will become the lenses of the eyes, will form. In addition, the maxillary and mandibular prominences enlarge and grow forward and towards the middle, eventually giving rise to the upper and lower jaws, respectively. In a 6-week-old embryo, the 2 mandibular prominences fuse to form the lower jaw. At this point, the outline of the mouth is visible. In the 7-week-old embryo, the maxillary prominences grow and fuse to form the border of the nostril and the upper lip. Merging of the maxillary and mandibular prominences forms the cheeks and the corners of the mouth. The philtrum of the upper lip and palate are also created at this time. In this flurry of activity in the first 7 weeks after fertilization, the 5 facial prominences give rise to the formation of the forehead and sides of the face, middle and sides of the nose, the philtrum, the upper lip, the palate, and the lower jaw. By the 7th week of human embryonic development, most of the facial structures can be observed. In the next few months of development, the initial cartilaginous skeleton of the face is replaced by bone, and there is an overall increase in shape and size of the different structures of the face. From childhood to adulthood, the face continues to develop through further growth and remodeling.
Okay. To summarize the previous slides, the primary palate is completely formed by the end of week 8 of gestation till end of second month of pregnancy. And the secondary palate is completely formed by the end of week 9 of gestation. Therefore, anything that happens after 9 week of gestation is unlikely to cause or prevent a cleft lip or a cleft palate. And now let's talk about terminology. What does it mean, primary palate? The primary palate comprises the anatomic structures anterior to the incisive foramen, alveolus, maxilla, piriform, lip. The secondary palate comprises the anatomic structures between the incisive foramen and the uvula. So, complete cleft of the primary and secondary palates involves the maxilla, alveolus, hard palate, and soft palate. Isolated cleft palate involving the hard and soft palate without affecting the alveolar ridge. Complete cleft of the secondary palate. And cleft involving only the soft palate and not the hard palate or alveolus. Incomplete cleft of the secondary palate. About common orofacial clefts. This presentation will focus on cleft lip only, cleft lip and palate, and cleft palate only. Orofacial clefts are commonly divided into 3 subtypes. They are cleft lip only, cleft lip with cleft palate, and cleft palate only. Cleft lip only is defined as the partial or complete fissure of the upper lip. Cleft lip can be unilateral or bilateral and can be associated with a cleft gum. Cleft lip with cleft palate is the most common subtypes of orofacial clefts and is defined as the cleft of the upper lip extending through the primary and secondary palates, with or without extension through the soft palate as seen in the second sketch. and cleft palate only is defined as the feature of the palate which can affect the soft and hard palate, or only the soft palate. And now shortly about formation of clefts. I would like you to understand that reference point of fusion is incisive foramen, and a fusion of primary palate and secondary palate is from this point to the frontal direction or distal direction, like zipper. Incisive foramen, it is a reference point, and like zipper, from this point is closing to right and left sutures in primary palate, like zipper. Or closing of secondary palate in distal direction, like zipper. Please remember it. It is normal process. And about formation of clefts. Failure or fusion of maxillary and medial nasal processes causing anterior to incisive foramen. Failure of fusion of palatine shelves posterior to incisive foramen. Cleft lip. Failure of proliferation of mesodermal cells in midline. As a whole, orofacial clefts affect an estimated 185,000 births per year worldwide, with a total prevalence of 15 per 10,000. As it was mentioned earlier, cleft lip with cleft palate are the most common subtype of orofacial clefts, with a prevalence of 6.7 per 10,000 births. The prevalence of cleft lip only is 3.3 per 10,000 births. And the prevalence of cleft palate only 5.0 per 10,000 births. The prevalence of orofacial clefts varies among populations and race or ethnic groups. For example, the prevalence the prevalence of cleft lip only or cleft lip with cleft palate is 21 per 10,000 in Japan, and 13.26 per 10,000 in Norway. The similar rate, like in Norway, 13.49 per 10,000 in China. Orofacial clefts may occur as isolated birth defects or be associated with other birth defects. It is estimated that 25-30% of cleft lip only and cleft lip with cleft palate are associated with other birth defects, half of which are due to syndromes, and are more common in bilateral cases. Furthermore, it is estimated that 25-50% of cleft palate only are associated with other birth defects. Let's talk about etiology. In etiology, they are divided three main factors: genetic, environmental, and multifactorial. Genetic group. Genetic disorders are classified into four groups: chromosomal, single gene, multifactorial, oral clefts, and mitochondrial. Environmental. Chances increases if more than one family member is affected. More the severity, greater the chances of recurrent in sibling. Higher risk is affected individuals is of less affected sex. Risk decreases in remotely related individuals. Consanguinity increases the rate because of sharing of genes. And multifactorial. The maternal smoking or tobacco exposure, viral infections, poor nutrition, certain medicinal drugs, teratogens like rubella virus, cortisone steroids, mercaptopurine, methotrexate, Valium, Dilantin. But there are a group of predisposing factors like high maternal age, diabetes, toxemia, reduced blood supply, folic acid deficiency, racial, mongoloids, and of course radiations. Now shortly about pathophysiology. There are different mechanisms and underlying cause for different clefts. For example, cleft lip mechanism. It is hyperplasia in maxillary prominence leading to inadequate contact with medial nasal prominence and intermaxillary segment. Due to or inadequate migration of neural crest cells or excessive cell death. And underlying cause of it, multifactorial, genetics or teratogens, teratogenic drugs, anticonvulsants like dilotine, vitamin A, vitamin NLX, oral anti-ache drug, Accutane. Cleft palate mechanism is a failure of lateral palatine process to fuse due to a few factors like inadequate growth, failure to elevate bow tongue, excessively wide head, failure to fuse, or secondary rupture after fusing. And underlying cause, multifactorial, like in the first case, genetics or teratogens, or only genetics, trisomy of a 13 pair of genes. And teratogenic drugs, for example, anticonvulsants. But higher incidence of cleft palate in females may be due to lateral palatine processes fusing about a week later, prolonged sensitive period. Now let's talk about classification of lip and palate clefts. There are many different classifications according to different authors. Let's begin from Bixler classification. According to this classification, Bixler divided oral clefts into 3 groups. First group, syndromic, single gene or chromosomal or environmental. It is 1% of a cleft lip and palate and 8% of isolated cleft palate. Familial. It is big group, 25% of cleft lip palate and 12% of isolated cleft palate. And isolated or non-familial. This group includes the most of cleft lip palate, 75%, and the most of isolated cleft palate, 18%. Davis and Rich's classification, developed in 1922. There are few groups. Group number 1, pre-alveolar process clefts affecting the lip. It can be, according to sites, unilateral, right-left, complete-incomplete, bilateral, right complete-incomplete, or left complete-incomplete, and median, complete or incomplete. Group number 2, post-alveolar process clefts affecting the palate. In other words, behind the incisal foramen, soft palate and hard palate. And third group, alveolar process cleft, any cleft involving the alveolar process. It can be unilateral, right or left, complete or incomplete, bilateral, right, complete or incomplete, and left, complete or incomplete, and median, complete or incomplete. Next classification, Victor Hughes classification. This author proposed all clefts divide into cleft lip, class 1 unilateral, notching of vermilion border, not extending into the lip, class 2 cleft extending into the lip but not including the floor of the nose, class 3 extending into the floor of the nose, and class 4 any bilateral cleft of the lip, whether incomplete or complete. Class 1 unilateral, notching of vermilion border, not extending into the lip. Class 2 cleft extending into the lip but not including the floor of the nose, and class 3 extending into the floor of the nose, and class 4 any bilateral cleft of the lip, whether incomplete or complete. Group B, cleft palate, class 1 soft palate cleft, class 2 soft and hard palate extending no further than incisive foramen, class 3 complete unilateral cleft extending from uvula to incisive foramen, then deviating to one side, and class 4 two clefts extending forwards from the incisive foramen into the alveolus. Fogg and Anderson's classification, 1942. This author proposed to divide orofacial clefts into hair lip, single or double, hair lip with cleft palate, isolated cleft palate, and rare atypical clefts, for example, median cleft lip. Kanahan and Stark's classification, 1958. That authors proposed to divide all clefts into cleft of structures anterior to the incisive foramen, clefts of structures posterior to the incisive foramen, and clefts affecting structures anterior and posterior to the incisive foramen. As can you see, it is a very simple classification. But according clinicians, better classification is American Cleft Palate Craniofacial Association classification, 1962. According to this classification, all clefts are divided into clefts of the prepalate, cleft of lip and embryological primary palate, cleft lip, cheiloscheisis, cleft alveolus, alveolar scheisis, cleft lip, alveolus and primary palate, chilo-alveolar scheisis. Second group, clefts of the palate, cleft of the embryologic secondary palate, cleft of the hard palate, orofacial, cleft of the soft palate, staphyloschisis or veloschisis, and cleft of the hard and soft palate or anastaphyloschisis. Third group, clefts of the prepalate and palate alveolar genopalatoschisis. And fourth group, facial clefts other than prepalatal and palatal, cleft of the mandibular process, nasoocular clefts, oroocular clefts, and oroaural clefts. In 1971, Kanahan and Starks proposed stripped Y classification. What does it mean? These authors schematically depict oral cavity like Y letter and divided it into different areas marked by numbers, where number 1 it is right lip, number 2 right alveolus, number 3 right palate anterior to the incisive foramen, number 4 left lip, number 5 left alveolus, number 6 left palate anterior to the incisive foramen, number 7 anterior hard palate, number 8 posterior hard palate, and number 9 soft palate. According to this classification, clinical situation can be right by few numbers. And next classification is Spinner's classification, 1973. According to this classification, there are different groups. Group 1, pre-incisive foramen clefts, unilateral, bilateral, and medial. Group 2, transincisive foramen clefts, unilateral, bilateral. And group 3, post-incisive foramen clefts, total or partial. And last group, group 4, rare facial clefts. But in 1976, Elsaki and Millard upgraded Kernaghan and Stark's stripped Y classification, and according this classification standard, Kernaghan and Stark Y strip was added triangles. Miller added 2 triangles over the tip of the Y to denote the nasal floor. This increased the number of boxes to 11, as box 1 and 5 nasal floor, right and left, block 2 and 6 lip, right and left, block 3 and 7 right and left alveolus, block 4 and 8 hard palate anterior to the incisive foramen, right and left, block 9 and 10 hard palate posterior to the incisive foramen, block 11, it means soft palate. The unaffected areas were not shaded, and the shading of the triangles denoted the distortion of the nose. And other very famous classification called Laschal classification by Okrins, proposed in 1987. Laschal is a paraphrase of the anatomic areas affected by the cleft, where L means lip right, first L, lip right, first A, alveolus right, first H, hard palate right. S, it means soft palate, median. Second H, hard palate, left. Second A, alveolus left. And second L, lip left. How can we use this classification? According affected areas, we need write some capital letters. Presented capital letter, it means complete cleft. A lowercase letter, it means incomplete cleft. And marks like dot or other mark, it means normal. For example, diagnoses like L, A, dot, 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 I, L, it means complete right cleft lip and alveolus, incomplete left lip. This lowercase letter L. As for me, it is so easy classification. Or, for example, in case we will write capital letters L, A, H, S, it means complete right unilateral cleft of lip, alveolus, hard palate and soft palate. And let's summarize previously information about classification, about types of cleft, lip and palate. Unilateral, bilateral complete, unilateral, lateral complete cleft lip. As for me, they're shown so understandable, different types of cleft lip and palate. Let's look it again, once again. 11 different types of cleft lip and palate. notice a reference point is foramen incisivum. So, let's go ahead. Which problems associated with cleft, lip and palate? Which problems? There are many different problems. Failure to gain weight. For newborns, it is very important to gain weight. Feeding problems. And as a result, failure to gain weight. Failure to gain weight. Dental problems. Skeletal problems. Part of feeding problems, a flow of milk through nasal passage during feeding. Poor growth, of course. If newborn will have feeding problems, of course, the child will grow so poor. Of course, speech difficulties, hearing loss, difficulty in swallowing, nasal speaking voice, language delay, recurring ear infections, change in nose shape. But as for me, it is change in nose shape. It is the easiest problem. Poorly aligned teeth, and of course, so big problem, social development. Let's talk more detail. Failure to gain weight and feeding problems. At first, I would like to show you normal process of feeding, of breast sucking. It's called latch on.
Latch-on is the series of motions in which a lactating mother brings baby to her breast and skillfully inserts her nipple into the baby's mouth when the baby wants to suckle, so that the baby's suckling and the mother's nursing can start smoothly. When the area around the baby's mouth is stimulated, a reflex causes the baby to open its mouth and start suckling. When the nipple is placed on the baby's tongue, the baby's lips flare, opening wide toward the outside of the nipple. In this way, the baby takes the mother's entire areola into its mouth. The mother should try to insert the nipple deep enough that the entire nipple, including the areola, is in the baby's mouth. If latch-on is shallow, soreness can result. The baby's tongue forms a U shape and wraps around to enfold the nipple. When this happens, the baby's tongue starts to make an undulating motion. At the same time, the mother's entire nipple begins to extend out from and contract back into the areola to move the milk down from within the breast out through the nipple. The release of breast milk is stimulated. The milk flows to the baby's mouth in time with this motion. This undulating motion is called peristaltic motion. As baby is feeding, the tongue forms a U shape and wraps around the nipple. The undulating peristaltic motion repeats over and over. This video was produced on the basis of research results using ultrasound. Although they cannot be seen from outside, these are the movements that occur inside the baby's mouth. If the mother skillfully inserts her nipple in the baby's mouth when the baby wants to suckle, the baby's suckling and the mother's nursing can start smoothly. Thus, the baby and mother can continue working together in sync.
Okay. And let's talk about feeding problems. Cleft lip. It means makes it more difficult for an infant to suck on a nipple. Cleft palate may cause formula or breast milk to be accidentally taken up into the nasal cavity. The oral nasal communication diminishes the ability to create negative pressure necessary for sucking. Can be nasal regurgitations of food, excessive air intake that requires frequent burping and choking. Feeding time is significantly longer and fatigues both baby as well as mother. Upper respiratory tract infections can develop. Specialized nipples and bottles are necessary to improve feeding immediately after birth. The most useful devices combine oversized nipples with reservoir spaces and large openings, and squeezable bottle to push fluid into the nipple assembly. Next big group of problems, dental problems. We can observe tooth agenesis like hypodontia. It is a most common problem in patients with lip and palate clefts. Supernumerary teeth, as usual, it is the second upper incisors or upper lateral incisors most common. Animal hypoplasia, cross bites, ectopic eruption, transposition and taurodontism, and the laceration. Next group of problems, skeletal problems. As can you see, as usual, the maxillary deficiency, mandibular prognatism, and class 3 malocclusion, and concave profile. Next problem can be nasal deformity and aesthetic problems. The nasal alar cartilage may be displaced or deformed, producing a noticeable deformity of the nasal orifice. Facial disfigurements, poor nasal shape, scar marks of surgeries, poor lip function during speech, poor dental alignment and smile.